This is the second presentation for focal lung disease, prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. Will be on consolidation, and by definition consolidation is the replacement of air in the alveoli by fluid or cells. Fluid may be transudated or exudate, means infection or edema, or it may be cells, whether inflammatory or malignant, like alveolar cell carcinoma and lymphoma. And usually the consolidation has some characters. It would start as small nodular opacities of ill-defined margins, and then they gather together, coalesce, and form larger masses of ill-defined margins, larger patches of ill-defined margins, which gather more together to form segmental, lobular, or whole lung opacification. Definitely, so long it is just replacement, there will be no change in size, no change in volume, no volume loss, and the presence of something within alveoli is not necessarily obliterating the bronchi, and so whether it is main bronchi or central bronchi. That's why we can see what we call air bronchogram, that is air delineating such tree within the involved areas. And the presence of consolidation beside solid organ or soft tissue opacity, like that of the heart, will produce loss of the differentiation, loss of the interface, and this is called the positive silhouette sign. So if we have, for example, lingular opacity, it will produce obliteration of the left cardiac border, while if we have middle lobe opacity, it will produce the right cardiac border. Consequently, you should consider it as starting by secondary lobule, then segments, then lobes, so it is limited by fissures. It cannot cross fissures, except if more than one lobe is involved. This is something else. This is the secondary lobule involved as opacified, obliterating the vessel inside. And imagine that this is central, not peripheral like here. So the bronchi passing through such an area will be delineated with air, and this will be the cause of air bronchogram. Causes of acute consolidation, as we said, it is either fluid or light edema or exudate of infection. So consider edema, consider pneumonia, consider aspiration, consider hemorrhage. All such things can produce acute consolidation, while chronic consolidation will shift to another group where there is neoplasm going on and increasing in size. Consequently, there will be air bronchogram and filling of the alveolar cells, alveolar spaces with malignant cells. This is characteristic in lymphoma and alveolar cell carcinoma. Second group of chronic consolidation is seen in the parenchymal phase of sarcoid, and this is an example of the chronic interstitial diseases of unknown etiology. The second group is the chronic interstitial the interstitial pneumonias, including organizing pneumonia, while there is another group called interstitial pneumonia of known etiology, here like alveolar proteinosis or eosinophilic pneumonia. These are, or hypersensitivity pneumonia, these are of known etiology. Here in this we have one with well-defined left cardiac border and one without or with ill-defined left cardiac border. Of course, if it is ill-defined, that means that the lingula is involved and this is positive, while if it is well-defined, that means the opacity is behind the left cardiac border, and that means it is a lower lobe opacity. So this group on the left are due to lingula, these two on the right are due to left lower lobe consolidation sparing or not affecting the left cardiac border. So what is this? If you look, you will find that the cardiac border is still there, while there is an opacity at the right paracardiac region. And if you look in the lateral film, and remember that if we go downward posteriorly, we should get more increased translucency, and here we have lost this sign, and there is opacification of the retrocardiac region. That means the silhouette sign here is negative, and that involvement is that of the right lower lobe. So long we have clear-cut right cardiac border, and we have opacification in the lateral film at the retrocardiac region, that means that the right lower lobe is involved in consolidation, right lower lobe consolidation. Here is the famous example of the middle lobe, where the right cardiac border could not be traced, and there is an opacity of still showing air bronchogram, and you can sure about the margin which is ill-defined, and it is located confined to the region of the middle lobe, so it follows the rules of consolidation, and at the same time it obliterates or it does not give us the chance to recognize the right cardiac border, denoting that this is a middle lobe consolidation and with positive silhouette sign obliterating right cardiac border. What is air bronchogram? As we said, air bronchogram is due to air outlined airway, which is made visible by filling of the surrounding alveoli, either by the fluid, the transudate, exudate, or cells. Of course, the main cause of air bronchogram will be consolidation, but sometimes in severe interstitial diseases, fibrotic changes around the main bronchi will show some traction of this bronchi, but it will not involve inside the bronchi, so you can get air bronchogram. But mainly the air bronchogram is due to consolidation, whether chronic, acute or chronic, and we have noticed that consolidation can be either due to transudate, edema, exudate, infection, cells, inflammatory cells infection, or cells malignant, lymphoma, and alveolar cell carcinoma, amongst other causes of acute and chronic consolidation. This is the typical appearance of air bronchogram, where the consolidation of the most of the left side, showing that air is delineating bronchi, the same as the left side, as the right side image, where we have irregular outline, sun ray appearance, speculation, which should raise the possibility of that one to be a central bronchogenic carcinoma on the right, causing associated distal consolidation with air bronchogram. Now this is a consolidation of the right upper lobe. As we know that the fissure, the oblique fissure, is starting at dorsal 4 and finish just posterior to the to the costophrenic angle anteriorly, just behind it, and it passed on at the hilum. If there is consolidation of the right upper lobe, it would produce opacification above that line. If you have consolidation of the right lower lobe, you will have consolidation below that line. But remember that on the right there is transverse fissure, which is faintly seen here, and that means that this part is made by the middle lobe. So we have upper lobe, transverse fissure, inferior part of the oblique fissure enclosing here the middle lobe, and then there is the lower lobe. What is involved here is whole upper lobe and partially of the middle lobe. The right lower lobe is not involved. This is the reverse, where we have an opacity with the right cardiac border can be seen clearly. Here it is. The right cardiac border can be seen clearly, and the opacity is obliterating the diaphragm and obliterating the right costophrenic angle. And you know that any structure reaching into the right costophrenic angle is a lateral segment of the lower lobes, whether on the right or the left. If you look in the lateral film, you will find that the opacity is mainly limited by the oblique fissure starting from dorsal 4 down to just behind the anterior costophrenic recess, and the opacity is superimposed on the lower part of the vertebrae, which should be translucent. You know that, so as we are going from up down, this area should be translucent, but being opaque, that is, there is pathology here. So this is the right lower lobe consolidation. Some words about pneumonias. We have the airspace pneumonia. You know the pneumococcal pneumonia, the known pneumonia, the one you know. There is segmental, there is non-segmental distribution. You might find air bronchogram, no volume loss. You have the bronchopneumonia, and here spreads into the alveoli, may cause obstruction due to mucus or due to inflammatory cells causing associated atelectasis. And usually there is no air bronchogram because it is not homogeneous. Interstitial pneumonias. The three famous interstitial pneumonias you know that cause acute interstitial lung disease are the viral, the mycoplasma, and the cytomegalovirus, mycoplasma, and BCB. And these involve the interstitial septa, resulting in reticular pattern as well. For example, in pneumocystis carinii, you will find diffuse homogeneous opacities with reticulation inside. Pulmonary infarct and pulmonary thromboembolism. Of course, the only way to diagnose pulmonary embolism, a gold standard, is the angiography, CT angiography for the pulmonary vessels. And here we have to revise our knowledge about a chest X-ray showing abnormality in pulmonary thromboembolism and pulmonary infarcts. Might be normal, might be simple atelectasis, might be small pleural reaction, or it might be areas of consolidation or atelectasis. And the gold standard is the presence of visualization of the clot within a pulmonary artery, either main pulmonary artery like here and there, or maybe as linear opacity within the artery, or sometimes it is seen in the periphery, but it's not apparent here. This is a chest X-ray where we hardly can identify that there is right infraclavicular nodules. There are right infraclavicular nodules here, See, of course, the presence of such multiple nodules is suggestive more of infection, and infection in such case is usually the upper zonal and posterior are granulomatous. Second one here is another example of the granulomatous nodules with calcification. Of course, these are not consolidations, these are nodules and showing marginal calcification here, and TB or hamartoma should be considered. Of course, hamartoma is more reasonable because there is no satellites and the calcification is on the surface. Here we find a nodule that is seen at the right base. So one of the hidden areas is the basal regions. Here we have multiple nodules and multiple rib lesions, multiple old fractures. So don't forget deposits. Soft tissue mass on the right with multiple masses scattered in the lung, appearance of multiple deposits. Large shadow opacity with at the right apical region, which is seen continuous up, causing some density here. This is the hair. It is extrapulmonary. It does not affect the vessels or bronchi. Here we have large mass at the center with irregular outline. We should consider bronchogenic carcinoma. And this is another one with this pneumonia affecting the periphery of the mid and partly lower zone. Again, this one should be considered again as either pneumonia or distal pneumonia, either pneumonia genuine or distal pneumonia due to central something here. Here we have ill-defined opacity with intralesional cavity, and this could be either fungus or TB. Here it is, left apical opacity with some cavitation inside. It is either TB or fungus. And here we find that the right cupula of the diaphragm could not be outlined, and you have definite discrepancy between these two. So this one is elevated and there is no breast on that right side, so there is mastectomy. So right mastectomy is elevated breast, elevated diaphragm, and right upper lobe opacity. It means that this could be radiation pneumonitis, and here is the appearance of radiation pneumonitis in such a case. Of course, there is some sort of emphysema resulting in herniation of the air behind the sternum. Thank you.